Good afternoon, one and all. Probably mine is just a continuation of Dr. Chital's talk. Failed ACL, large tunnel defects, and early OA. How do we manage that? We all know two-stage procedures, bone grafting, and second stage HTO with the ACL reconstruction has been time-tested technique, and we have all had good results with this. Longer recovery period and lengthier rehabilitation and return to sports, which is delayed, may be a concern for some. Can we cut short this period of time? Let's just look into this case. 38-year-old male complains of right knee pain and instability with mild deformity. He comes to our OPD after about 4 years after the second injury. His index surgery was done about 10 years back, the ACL reconstruction. He twisted off playing football 4 years back, and since then he's been dangling with this problem without any remedy. He's not consulted many doctors as well, and he's been pulling on. But now he's got pain and instability, and he wants this to be catered to. On examination, anti-drawer, grade 3 Lachman, and a grade 2 pivot shift test. We get an X-ray. X-ray looks as expected, medial compartment OA with you can also see a little largish tunnel here, and we investigate further, get an MRI scan, ACL graft ruptured at the femoral attachment site. What's also worthwhile noting here is this huge tunnel dimension of his tibial component. We get a standing scanogram, few parameters, typically the MPTA altered here, and probably the alpha angle is about 8.3, which would have to be catered to when we operate. CT scan reveals a good tunnel placement, a femoral tunnel diameter of about 11.9 mm, but the tibial tunnel diameter is about 20.5 mm, which is quite large. Tibial slope, as I said, was pretty much normal. Now the challenge is what we have. We all know that about 14 to 15 mm of tunnel dimension is acceptable, and we could go ahead with a single stage procedure. Anything beyond 15 to 16 mm is the critical tunnel diameter, which would probably require two-stage surgery. And typically when it's in an anatomical position, what are the challenges we have here in this patient? Larger tunnel dimensions, and the patient who's also got a medial compartment OA. Let me just go on to the first ARS question. To the audience, revision ACL or revision ACL with HTO, what would be the choice here? Pretty much expected revision ACL with HTO. Let me continue that. One more ARS question here, single stage or two stage? How many of us would go in for a single stage, and how many of us would go in for a two-stage procedure? ACL with HTO, I'm talking about.
Is the ARS timer on?
Okay, 80% go ahead with two-stage surgery. Our plan here was a single-stage procedure, high tibial osteotomy, revision ACL reconstruction with the BTB graft, and tibial tunnel management with the allograft. Intraoperative arthroscope, we can see here the ACL fibers are completely torn. Moderate medial compartment OA, meniscus, little bit of a degenerative changes. This, I would put it as a grade 2 OA on the medial compartment. What did I do here? Went ahead, tunnels were well in place, anatomical tunnels. I didn't have to do much about it, just remove the grafts there. Since it was a soft tissue graft, when you remove the grafts, you would see that the tunnel is not too big on the femoral side. I took a 11 mm reamer and reamed it gently so that I can get some good bleeding surface on the edges of your tunnel. On the tibial side, just cleaned off the soft tissue, took a curette and just scraped off the margins. Didn't go to ream it, just left it at that. This was a huge irregular defect of the tunnel, and you can see this is an oblongated tunnel. Took in a BTB graft of 11 millimeters bone plugs on either side. Went ahead and did an HTO. How do I do my HTO? before I do my HTO, I just put my 8 mm reamer into the tunnel. That makes my cuts easier. I just go below that, 8 mm opening, and fix the HTO with a plate. Then took an allograft of about 1 centimeter bone allograft and a screw of 10 mm. After passing the graft, this was fixed this way. First the graft, then your allograft and the screw. It's a 10 mm bone plug what you have, and then you have a 10 mm screw, and in between you have sandwiched your allograft, and as you push in a screw, the allograft just spaces by and fills in the defect. And if you see that on this side, you have a good, nice filled tunnel.
Chirag, what are your screw sizes? I mean, because they are very critical. What size screws?
10 mm screw. So I had a 11 mm tunnel on the femoral side. It was 11.9. So my graft was 11 mm there on the femoral side. I used a 7 mm screw for the femoral side.
7 mm on the femur?
Yeah.
Okay.
It's a tough bone.
And the tibia?
Tibial side, it's a 10 mm screw what I've used here.
And it's a biocomposite screw?
Biocomposite screw.
Okay.
And Chirag, what is your uniplanar or a biplanar osteotomy?
It's a biplanar.
It's a biplanar.
Yeah. Biplanar osteotomy.
Because biplanar osteotomy along with the tunnel, it's sometimes very difficult because your biplanar comes.
Yeah. But you see here, my osteotomy level is much lower than that, and my tunnel is just posterior. If you see the preoperative imaging also, I have enough space to go ahead with my biplanar osteotomy. I'll just put off the MRI. Yeah. Here is the tunnel, and tubercle is here.
Just a comment that these bio screws, when you put against the bone plug, so it is not easy to put them. You can actually break those screws. So either tap it while putting it, or it is difficult to put these bio screws against a bone plug. Metallic screws are easy to put. Any experience of the in the house?
Yeah. So there's something called the tunnel notcher which you get. You can notch your tunnel.
You can actually tap them also. You get a tap of that.
Yes.
So you can tap it and then put those screws. Otherwise, you can, if the screw breaks in between, then it's a issue.
Bhushan, do you like to use these biocomposite screws with BTB grafts, or are you happy with metal?
So you already got a wide tunnel.
Yeah.
You know that there will be some osteolysis around the bio screw. You put some allograft, that's going to be absorbed very fast. So you're going to get a very big tunnel. So my choice always is using a metallic screw as far as possible, especially when you're using a bony graft. Yeah. If you're using a soft tissue graft and if you are happy with your bio screw experiences, then you can use bio screw.
I never use
my take.
Yeah, I never use metal screws in my any BTV cases, primary or revisions. I'm happy with this biocomposite screws. Never given any trouble still now. Yeah.
One more point: the standard companies have withdrawn the metallic screws. You only get bio screws now. No. Local companies, yes, but MyTech, I have asked them to give metallic screws. They say.
Chirag, instead of a bio screw, any experience with using a peak screw in such cases?
You can.
Because it does not cause local osteolysis.
It doesn't cause local osteolysis. That's one thought process, but I'm somehow comfortable. The absorption is little. So yeah. No, this is the Smith & Nephew screw. Yeah.
So what was the correction amount in this case?
8 mm.
8 mm correction. Yeah. His MPTA was 86, if I'm not wrong. What I'm trying to come to is there is some amount of intra-articular wear also.
Yeah, there is.
So with respect to the correction also, if you are planning a bigger correction, my question is, when we are using the nuclip type of plate, we do not have the option of compressing the hinge as much unless you use a hinge screw. I'm concerned when your ascending osteotomy has happened, is there a Takeuchi type 3 fracture that has happened out there?
Yeah, exactly. I'm coming to that.
Yeah. So when you're doing these cases, is it better to use an angle stable plate? Is it better to make sure the hinge is well compressed, and therefore probably a staged procedure is better so that all these implications can be handled? So what was your experience you could just share?
Yeah, so exactly what happened here, I didn't realize till I put in my plate there, I did have a Takeuchi type 3 intra-articular fracture here.
Well, full marks to Nagaraj for being so wide awake. Amazing.
Yeah. That is probably one of the drawbacks of this plate probably, or else my osteotomy wouldn't have been completed and I distracted it much, probably prematurely, just to save the time. It was the longest procedure, and this is something which can happen on table, so we need to be a little guarded about this. We need to take our time and do that.
Chirag, I think Mukesh wants to make a point
Yeah.
before you proceed.
Chirag, we all know that artificial bone will resorb, and in such cases, why not to use simple autograft? Be
You
more
can use
secure.
an autograft, no problem. I'm happy using allografts for all my HTOs, for my...
For HTOs and fine, but here, if it get resolved, your tunnel will again widen and your graft will again have issue.
See, let's look at it. Ultimately, what are we dealing with? We are dealing with the biology. We have a tunnel bleeding there. We have our blood clot, which is going to be ossified, nothing else. All these are just augments, I feel. I mean,
Chirag,
how does your BTB heal or anything heals in that matter? It heals with a tunnel filled with
Chances
blood
of
and
bone
that's going to be
resorption are
ossified.
less in autografts.
You
That's
just
the
need an
only point.
osteoprogenitor. Yeah, probably that's another
Only point.
way of looking at it. Your osteoinduction would be much better with the autograft. But yeah, this fellow had too many things I didn't want to.
Chirag, what's your opinion on the off-the-shelf products which harden after you inject them? So gel kind of materials.
For this?
Yeah.
No. Definitely not. I mean, it's like putting a glue, you are telling.
Yeah, so something like bio-inductive putty or
Could be,
something.
but I have no experience with that. I mean, anybody can share that. I mean, you're free to. So that's what we have. We just salvaged it with one screw. Just from medial to medial side, compressed the fracture side. 3 months post-op. Clinically, he's well, limb in alignment, but has the graft healed? Was our question. Got a CT scan little prematurely, just out of anxiety. Look at that. That's my tibial tunnel. You can see well in this. You have a screw, you have a graft, but you can see this here, a little bit of an ossification just setting out there. That is the graft. That's an axial films, and looking at the sagittal films here, there is no space between your screw and your graft. That means it's snug and firmly fitted there. If I see the running images here, there's a little bit of calcification developing there in your graft side. Here, again a calcification there. We can see this bone graft over here. I do need to get his MRI scan or a CT scan to probably establish this technique in about 6 months to 9 months. This is just a premature CT scan. Let's wait and watch. For now, it's working, and if it's working, well and good. Revision ACLs, 2-stage procedures, longer recovery, rehabilitation, delayed return to sports. So can we cut short this time with a single stage procedure, what we call it as sandwich procedure?